Hi there, I'm Chris Bashi. I'm an emergency medicine physician at Mercy Hospital St. Louis. Today I'm going to teach you the Mercy Pit Crew CPR model. It's our hope that all of our services that we provide medical direction for will adopt this model so that we can standardize the way we provide CPR care to our patients in cardiac arrest. The reason we're doing this is we would like to minimize compression interruptions. We find if we spend more time doing compressions, we can actually increase our return of spontaneous circulation rates. If you look at the graph there, you'll see that that is showing us the coronary perfusion pressure, which is the blood that's going to the coronary arteries during CPR. And you'll notice that when we stop CPR, that coronary perfusion pressure drops dramatically. And when we start CPR again, it takes a while to get that coronary perfusion pressure back to where it was before. And so if we stop CPR multiple times, we have a hard time maintaining an adequate coronary perfusion pressure during the resuscitation. Traditionally during CPR, there were multiple tasks we would have to perform where compressions would be stopped. And so what we're going to try and do is not stop compressions to accomplish some of these tasks. The first one was airway interventions. It's very hard to intubate someone during CPR, and so a lot of times compressions would be stopped to accomplish this task. Well, if you look at the teaching from American Heart Association, we are no longer focusing on an ABC model where the airway comes first. Instead, we've focused on CAB, which focuses on compressions, and so our airway interventions are not as important. This means we're using supraglottic airways, or we're using a video-assisted device such as the King Vision to place an ET tube. So we're not going to stop compressions at all to accomplish an airway intervention. The next would be IV access. We can put an IV in the patient's arm, but a lot of times that interferes with the compressor who's trying to accomplish chest compressions. So what we're going to do is use an intraosseous device in many of these cases, which can be done in the leg, and so we don't have to stop CPR to accomplish that. Now we do have to stop CPR for a pulse check. We also have to stop for a rhythm analysis, and we have to stop to defibrillate the patient and to change compressors. But instead of doing those all individually, we're going to try and use this Pit Crew model to accomplish all four of those tasks within a short 10-second pause by coordinating all of these movements. Now, if we're going to move the patient, we have to stop CPR a lot of times, or we have to use a Lucas device, which would provide automatic chest compressions, and we'll talk about that. But we are working most of these patients where they fall, so we are not going to make that transport decision until at least 25 minutes into the resuscitation. So for the most part, we are not going to stop CPR to move the patient, at least in the short term. Now let's look at this Pit Crew model. Basically here what we're doing is we're choreographing the task to minimize interruptions. And this allows us to focus on compressions, and that's basically what's most beneficial to the patient's survival. This is being done successfully across the country by multiple EMS agencies. This is nothing that we've invented, but certainly we've seen it used successfully across the country, and we've had some success locally with other departments here, and so we'd like to bring that model to our services that we provide medical direction for. When you design a Pit Crew model like this, though, it has to be specific to each agency, and so this is a general overall review of this model, but your specific department may have to tweak this a little bit based on things like how you staff your pumpers, or what kind of level of training each of your personnel has. Also, maybe what monitor that you're using may also depend upon how you apply this protocol. So we'll talk about a few different things as we go through this. So our goals here are to provide high quality chest compressions. We don't want to stop CPR any more than 10 seconds every 2-minute cycle. We want to do asynchronous controlled ventilation, and we're not necessarily going to do that in the first few minutes, which I'll show you. Everything else is secondary. So our medications, our IV access, all of that is secondary to our main goals, which are high quality chest compressions with limited interruptions. Now our model is going to take into account several different scenarios here. The first would be where the pumper arrives first. The second would be where you would have an ambulance arriving first on the scene. And then obviously where both of those pieces of equipment may arrive together. We're going to do chest compressions that are anywhere from 100 to 120 per minute. If you remember the song Staying Alive, If you do compressions to the beat of that song, that'll get you about 103 compressions per minute. You may want to use a metronome. That could be something you could provide to your crews, or some of the monitors that we use have a metronome function if you're using a monitor that has CPR feedback, and that might be something that you turn on to get us a compression rate of anywhere from 100 to 120. Now we're going to do asynchronous ventilations, and we're going to do that using either a supraglottic airway, such as the iGel, or an ET tube, but whichever one we use, we're going to monitor the end tidal CO2, and so that's something that we want to make sure that even if we're putting in a supraglottic airway, we monitor that end tidal CO2, and we record that end tidal CO2 reading in our trip sheet. Now to ensure that we do 2-minute cycles, you're going to need some sort of stopwatch or some way to time these 2-minute cycles. Some of the monitors that are out there have an AED mode, which will actually time this 2 minutes for you. And so if you have one of those monitors, you can use the AED mode for this task. So let's just show a little bit of a video of how this works when the pumper arrives first. We see rescuer 1 here is going to go immediately inside to begin chest compressions. And the remaining rescuers, number 2 and 3, will bring the equipment in. The idea here is we want to get CPR going as soon as possible. So when the pumper arrives first, you'll see that the crew will arrange themselves around the patient in this configuration, kind of a triangle configuration. The first guy who we saw get off the truck, rescuer 1, will assume what is noted there as the BLS-1 position. This does not have to be a paramedic. This could be a first responder or EMT, depending upon how you staff your pumper. This person is our first compressor. They will immediately begin CPR with the goal of doing 2 minutes of CPR or 200 chest compressions. You'll see what is marked as BLS-2. That's our second responder. This does not have to be a paramedic. This could also be a first responder or EMT. They will attach either an AED, if that's what you carry on your pumpers, or a monitor with defibrillation capability, and set that up to fire that device to defibrillate the patient. Once that BLS-2 rescuer has hooked up the patient to a device that can defibrillate them, we can go ahead and use that defibrillator. You'll notice that there's an ALS-1 position here. That's the airway position. That can be a paramedic, preferably, which will go to the airway position and immediately place either a supraglottic airway like the iGel or an ET tube, depending upon that medic's preference. Our protocol allows for either device to be placed, but we would like compressions to be continued throughout this procedure, so we are not going to stop compressions to obtain an airway. So it's probably easy just to place a supraglottic airway as long as you're getting that airway to work correctly. You can also place an ET tube if you would like, but it might probably be easier to use a video-assisted device to do that during compressions instead of the traditional laryngoscope. At this time, we are not going to start an IV, and we are not going to give medication. So when the pumper arrives, we're going to focus on BLS care, go ahead and get compressions going, and let's prepare to defibrillate the patient. Once that defibrillation is accomplished, BLS-2 position will then start CPR. And so that's our second compressor. And so BLS-1 position has been doing CPR while we've been preparing to fire the defibrillator. Once the defibrillator fires, we're going to give that guy a break, and BLS-2 rescuer will start chest compressions. And let's take a look and see what that looks like. So here we see our patient. We have the arrival of our pumper crew. You see the 3 go to their respective positions. Rescuer 1 immediately starts CPR. The person at the head sets up an airway, while the person that is in the rescuer 2 position prepares to fire the defibrillator or the AED. Rescuer 3 is going to place an iGel airway, which for our purposes here is simulated. Rescuer 2 is now ready to fire the AED. He's going to fire off the AED and then immediately begin chest compressions. Rescuer 1 now waits to do compressions again, while the rescuer at the airway bags the patient every 6 seconds. Now, when the ambulance crew arrives, they're going to take position at the patient's legs. You see we have positions ALS2 and ALS3 noted on either side of the patient there. The paramedic who is in the ALS2 position, this would be somebody who probably drove the ambulance. They will go ahead and place an IV or an IO, most likely an IO in the patient's leg, provided there are no contraindications to that. That person's job is going to be then to give IV or IO medications when the time comes. That will be their sole responsibility. So this rescuer has to obtain IO or IV access and give medications. The person in the ALS3 position is going to take possession of the cardiac monitor, and this is going to be our code commander. This person is probably the tech on the ambulance. They will assume the role of code commander and drive the entire resuscitation. It's their job to instruct the other crew members on how to perform during this pit crew resuscitation. They will order the medications to be given, and they will supervise the chest compressions. And so you'll see here, this is the arrival of the ambulance crew. The code commander on the left of your screen takes possession of the monitor, and he's going to be the code commander. You'll see the other rescuer immediately arrives and begins to set up an intraosseous device to be placed in the patient's right leg, and that's where we're going to give medications. And all this is occurring while the pumper crew is focusing on the compressions and airway of the patient. Now, when we have to change compressors, this will happen at the end of each person's 2-minute cycle of CPR. So as soon as we are done with compressions, you will change with the person who is doing the airway. The person immediately across the chest from you will start compressions. So we always have somebody across from the compressor ready to start compressions when the 2-minute cycle is up, and you will always switch with the airway person when you're done with compressions. And so in this way, you will do 2 minutes of CPR every 6 minutes if you're on the pumper. So for that 6-minute cycle, 2 minutes of it you'll be doing compressions, 2 minutes of it you'll be doing airway, and 2 minutes you'll be resting and waiting across from the compressor to start CPR. And so we'll see how that looks here. The compressors switch with the airway rescuer after the 2-minute cycle. You'll see this is going on while the patient is defibrillated. And as soon as the patient is defibrillated, the rescuer across from the compressor starts CPR. And in this way, we've coordinated a lot of tasks during that 10-second pause to defibrillate the patient. Now, if you have extra personnel, they can go out and get equipment. They can talk to family. They can basically get a history for you. But if you do not have that, the person who is located at the patient's right leg, which would be on someone from the ambulance crew, can go and get equipment. They can also speak with family and get a history for you. That person, once they have established IV or IO access, only has to give medications every 3 to 5 minutes. So they have some free time where they can get this history or go for equipment. The best thing to do, though, would be to bring the equipment with you when you start the resuscitation. Now, what if the ambulance arrives first? If the ambulance arrives first, we are going to focus strictly on chest compressions. We are not going to worry about an IV. We're not going to worry about medications. And for the first 400 compressions, we're not going to worry about the airway. So the first person into the house, which would be the ALS1 responder, will immediately begin chest compressions, hopefully for a 2-minute cycle. The second paramedic in the ALS2 position will operate the AED or cardiac monitor and prepare to defibrillate the patient. Once the patient is defibrillated, that ALS2 rescuer will take over compressions, and the ALS1 rescuer will wait to begin compressions. If during this 2-minute period, that ALS1 rescuer can place an airway or put the patient on just a simple non-rebreather, they can do that as well. But we really don't want to focus a lot on the airway at this point for the first 2 minutes of the resuscitation. Most of these patients that have a cardiac arrest have an adequate amount of oxygen in their bloodstream and can survive for several minutes without an airway. And so we're going to focus on our compressions. Hopefully we'll get a pumper crew there shortly. But if we do not, Once those 2 cycles of CPR are done, one of these rescuers will move to the head and take over the patient's airway. When the pumper crew arrives, the rescuers that are on the ambulance will slide down to their traditional positions on either leg. One of the paramedics in the ALS2 position will place an IV or an IO and give medications. The other one will keep the cardiac monitor and will serve as the code commander. The pumper, when they arrive, will take their traditional positions around the patient in the triangle configuration and focus on compressions and the airway. Many of our services are carrying the Lucas device. It should be known that this device has not been shown to be superior to high quality chest compressions done by a rescuer. So it's not a device that we have to use. It is not superior to high quality chest compressions. The problem with this device is it may take longer than 10 seconds to apply. Certainly, there may be a way you can get this on the patient in less than 10 seconds, but it's going to require a coordinated move. This is kind of concerning because we don't want to stop CPR longer than 10 seconds. In discussing the use of this device, we currently feel that this device should only be used when the decision is made to transport the patient. And so if you're going to use this device during the transport of the patient, that would be fine. But because of the length of time it takes to apply this device in a coordinated fashion, we feel this device is best used later in the resuscitation after 25 minutes of high quality CPR has been done, and then you decide you want to transport the patient from the scene. Now, you can apply this device after you get a return of spontaneous circulation, because if the patient arrests again, you'll have the device on and it can go ahead and be operated. But we really don't want this device currently deployed until the decision is made to transfer the patient off the scene. In years past, we would immediately take cardiac arrest patients to the hospital. But what we find is that trying to do CPR in a moving ambulance is very difficult, and it's not beneficial to the patient. So for the past couple of years, we've been working on where they drop, and I think that's a practice that should definitely continue. Obviously, if you find the patient in a hazardous environment, you may need to move that patient a short distance to where the environment is safer. But for the most part, we want to work these patients on the scene and minimize our interruptions in chest compressions. Keep in mind that there is nothing that we have in the emergency department for a patient in cardiac arrest that you don't currently carry in your ambulance. These patients need chest compressions, they need defibrillations, they need an airway, and they need medications, all of which you've brought to the scene with you. So there really is no benefit for just removing them off the scene and driving lights and sirens to the hospital. And we certainly know that CPR in the back of a moving ambulance is not very effective. Now, the question always comes up about public places. But again, we still want to work them where they drop for at least 25 minutes. The current school of thought is that we're not going to leave dead bodies in public places. So if you decide to terminate the resuscitation, we currently do not have a plan in place to leave someone who's deceased in a public place. So those folks will have to be transported off the scene. But again, we're not rushing to transport them just because they're in a public place. As many of you know, I'm a hockey fan. In the NHL, there have been 2 cardiac arrests of players on the bench in the past 10 years, both of which were worked in front of 19,000 people where they fell, and both of which were resuscitated successfully. So, just because you're in a public place doesn't mean we have to immediately scoop and run these people to the hospital. So go ahead and work them where they fall, even if they're in a public place. But if you decide you want to terminate the resuscitation, currently we do not have a policy in place for leaving someone who's deceased in a public place. Now the question comes up about dealing with the family. We have received no complaints in the past few years from any family member who is upset that we didn't immediately bring their patient or the family member to the hospital during cardiac arrest. The thing you need to tell the family is we have brought the ER to them. There's nothing that the ER can provide that the ambulance can't provide on the scene. And so you want to involve the family early if possible, explain to them why you're not moving the patient, tell them what you're doing. When it's time to terminate the resuscitation, discuss the decision with them a few cycles before you terminate. That will make that a little bit easier on the family. But they need to know that at some point, if we have not received any kind of spontaneous circulation from the patient, that we're maybe going to terminate this code in the field, and that additional attempts at resuscitation will be futile. And so be direct, be specific, tell them what we're doing and why we're doing it. And if we need to terminate that resuscitation in the field, involve them a little bit early in that decision if it looks like things aren't going well. Thanks for listening. Some people confuse crazy with passionate. I can tell you I'm very passionate about this pit crew model. We have seen a lot of success with this pit crew model across the country, and I think we can duplicate that success here locally if we practice this a little bit. Where we go from here is after you guys watch this video, we're going to try and get out in the next few months to visit all of our local departments and work on this with you in a simulation. And hopefully we can teach it to you rather quickly, and then we can get it deployed by this late summer or fall as a protocol as far as how we handle arrests in our communities. If you have any questions on this, please don't hesitate to contact myself or John Wilmus. But again, I think this is something we can do and we can do successfully, and I think that once you guys do it a little bit, you'll really see some success with it, and we'll be happy with it. So again, thanks for your time. And we look forward to coming out and working with you on this in the next few months.